after public comment. Attorney Tucci, are your witnesses all available? You're on mute.
Yes, I can confirm all our witnesses are available.
Okay. You know how they used to say, can you hear me now? Can you hear me now on the phone? The new thing is going to be, you're on mute, right? If it's not already, you know. So Mr. Carney and Mr. Clark will do the questioning. They will either identify the witness that they want the answer from, or they may just ask for the best witness available to answer their question. So we're going to start with Mr. Carney. Oh, Brian, you're on mute.
Apologies. Good afternoon, everybody. First set of questions revolve around clear public need. Thinking probably that Ms. Chaffin would be probably the best person to respond, but I'll let you make the decision. First question revolves around pre-filed testimony asserting quantified gap in care and sort of your bed need analysis that we spoke to earlier. First question is, most of the focus of it was on national rates. How can we be assured that these national rates correspond with the need for inpatient rehab in Connecticut and the proposed service area? And further, how do we know that discharged patients from hospitals here in Connecticut are not, for example, older or sicker or unable to tolerate 3 hours of therapy per day and maybe a more appropriate referral for SNF than IRF?
This is Marty Chapin. That is appropriately me, I believe. I would refer you to Exhibit C of my pre-filed testimony to go from national data to Western Connecticut data. And in those exhibits, that is where Fairfield and Litchfield County data was utilized. Now, to your point, it was in comparison to the national average, but when you look at those county data, data points, that is part of the assessment of need in terms of, if this makes sense, the general acute care utilization is consistent with the national average, and SNF and Irf are so disproportionate. So again, I am still using that national benchmark, but it's at least at the county level. That's one comment to answer your question. The other, in terms of the age and the medical complexity of the patients, because the SNP and IRF are so disproportionate to what we expect, based on the data and the experience of Encompass, I don't believe that Connecticut is so different that you have a much older population or much sicker population. I've not seen that data to say that that's why they're not getting care. So 2 points. One is, on a national basis, and again, I am going national, Encompass's average age of their Medicare fee-for-service patient is 73. So they are experiencing taking care of older patients. Dr. Charbonneau can address that better. That's one comment. And I know I keep getting beaten up for only having 3 physician letters, but the physicians that represent themselves and their groups talk about patients that they have seen that need SNF. I don't know if that addresses your question or not, well enough or not.
Yeah, I mean, did you look at the data relating to sort of, you said you looked at age, the age differences. Did you look at the whether patients are sicker or not? And the term is escaping me right now, but hospitals have a term for sicker patients compared to less sicker patients, an evaluative term.
I think case mix index, does that ring a bell?
That's it.
Kind of like the thing, right? Okay. That I was unable to get that data because, unless I'm mistaken, as a new provider rather than existing, we did not have access to your all payer database, the APD database. And that, as you know, is a wealth of knowledge. So I do not have the CMI for existing providers.
Okay. Let's see. Besides you predominantly looked at these Medicaid conversion rates for rehab. Did you look at any other types of measures like historical utilization trends in the state for rehab or such, in addition to your main focus?
That's a good point, and I looked at the most recent 2 years only. So if we look at fiscal year 19 versus fiscal year 20, there has been an overall increase in patient days. In fact, I have that data. Yeah, the patient days increased slightly from the 42,000 or 41,943 on C1 page 74 to 43,289. And that recognizes, of course, we do have COVID in 2020. So the patient days went up despite that, but I did not go further back to answer your question.
Okay. And this is last thing's not really a question. It's more of a follow-up to hearing officer Yandel's request that that you provided with sort of the links related to the numbers that you've used for Medicare fee-for-service beneficiary rate of 56.8%. National Rehab admits of 59%. Hold on.
Yes, I will get you the links to make sure I understood. I will get you the links for the database that gives the county level data and the state data for the utilization rates. And then tell me your second part again. I want to make sure I give you everything.
Yeah, it's like all the sort of pertinent figures that you use. So I gave two examples: the Medicare FF fee-for-service beneficiary rate to 56.8%, the National Rehab admits percentage of 59%. So the relevant numbers that you're using in your methodology, so that we can go and verify that on our own without having to spend tons of hours. So we'll call this like late file 1.
Okay, yes, I'll give you the links, or I may even send a file on one of those. It would maybe be easier if I just send you an Excel file.
Okay. All right, second question. Pre-filed testimony states that although the population-based methodology results in an estimated inpatient rehab facility of 48 beds, Encompass Danbury believes that a 40-bed facility is the right size facility for today. Please explain the rationale for this statement and describe the criteria like facility space, volume, cost, etc., used to determine this figure as the right size, the 40-bed.
I can address it, but I'm probably not the best person. I would think that Pat Tour is probably better positioned for that.
Okay.
Carney, can you repeat the question?
Sure. So the inpatient, the bed need methodology came up with 48 beds. However, in testimony was stated that the 40-bed facility is the right number. So I was wondering, how did you come up with that rationale for the statement? Was it based on facility space, volume, cost, or what? How did you determine that?
Sure. So thanks for the question. That's more based on us. We think that's the right size facility for now to allow us to grow into a potentially larger building down the line. So positions for growth while being conservative with what we build out for now. I don't know if it's me. I think you're muted, Mr. Carney.
Do you know what your bed occupancy rates at your other IRF facilities are, how they run?
Yeah. So and I was gonna, I'm glad you asked. So just across the state border in Massachusetts, we operate with an ADC of 328 across 4 hospitals and 7 locations because there's 3 satellite locations. And that's an average per facility of about 82. So that, I don't have the exact occupancy percentage. We can get that for you. But you know, that it's a matter of us capturing the right patients at the right time from the acute care hospitals that would otherwise go and be going to skilled nursing facilities, much like what's happening in Connecticut with the overutilization of SNF.
Yeah, so I think I would appreciate if you could give me like occupancy rates for maybe like your 3 closest facilities or something. We'll call that late file 2.
Yeah, so I can give you our, the closest facility to you is in Ludlow, Massachusetts. And over the last 4 years, that's a 53-bed hospital that has a 4-year ADC of 48.4. So 91% occupancy. But we can give you the additional facilities that you're looking for as well.
Yeah, that would be good. How about, you know, the three closest? I think that would be appropriate.
We'll do that.
Um,
We'll do that. Thank you.
All right. Next question relates to sort of volumes and your projected volumes. So your projected volumes indicate for the first 4 years, first year I understand is partial. Discharge volumes are to be 92, 623, 793, and 963 respectively. So I was kind of wondering how those volumes were derived. I really didn't sort of see. I mean, I saw the bed need methodology, kind of understood how you got to the beds, 48 beds, but
Sure.
how did you come up with the 92, 623, 793, and 963?
So I'm happy to take this question, or Jennifer, or Attorney Fusco, I can turn this to Marty or Bill Heath if they would prefer, but I'm happy to give that a shot as well.
Yeah, you can answer. You can answer.
Yeah, so we have a lot of experience opening new hospitals. You know, between this year and 2023, we're opening 32 new hospitals across the company, and we have 144 hospitals now. And when we go to model out what a potential growth rate will look like in a hospital year over year, we look at comparable markets from a 65 plus perspective from an age demographic. We'll look at claims data from the different service areas and what the ramp ups were in our historical experience has been, and that's what we use for that modeling.
Okay. So like, what about for like the specific number, like 623? Like, was there some math used in determining why 623 and not 625 or 7? You know, I get you're basing it on sort of. I think it would be better for the record to be more complete if we had some kind of calculation as to how you arrived or derived those numbers, other than your experience and other facilities.
I'm sorry to interrupt, Brian, but we can get that from the Encompass finance folks who did the projections. I mean, I don't think I have them here, but I can get it. I can get sort of an assumptions if you want that in a late file, more detailed assumptions.
And
Yes,
let me add to that if I can. Part to follow up on what Pat said is the actual discharges and days are a function to some extent of the expected occupancy. And so if we have the target, this is my fault, I probably should not have rounded to 84.8. I probably should have used 85. So if you step back and think of it in terms of the 55%, 70%, and 85% to follow up on Pat, that is kind of the target. And then based on the length of stay, we had our discharges. The partial year number is based on the first quarter ramp up. So I think we owe you some written explanation to give you a little bit better explanation than this broad picture I'm giving you now.
Oh, that would be great. I would appreciate that.
Okay.
Yeah, and the first year I think is 3 months or something like that. So I get the lowness of the number. So
That would be a late file 3.
yep. Okay. Next thing relates to sort of referral sources. So I'm you're stating basically that your projected volumes are going to be based on 90% from referrals from hospitals, 8% from physician offices, and 2% from skilled nursing facilities. Again, how did you determine this breakdown of referral sources from your other facilities? Is that typically what you see?
This is Marty. I'll go big picture and then Pat can add to it if he needs to. That's exactly right. This is based on Encompass's experience that they typically get those percentages.
Okay. And again, I'm just, following up. I think we touched on this before, but it's important for us to be able to validate, claims that you make regarding your volumes and where they're coming from. So I'll ask kind of again, it's like, do you have any established commitments from any of these referral sources, whether it be hospitals or area physicians, where you actually have some kind of in-place agreement that says, all right, well, my practice can provide you with, approximately 10 referrals a year, or anything concrete that we can add as an evidentiary finding to the record.
Okay.
Marty, did you want to take that? Or are you just going to provide that?
Pat, I mean, my thought is if you can discuss it, that's better. We'll provide
Yeah.
something.
So the only thing that I think I can add is, and I think it's premature to seek a commitment in the absence of an approved CON. And even when we have a CON, what we would try to do is we would begin creating relationships in the market, educating. A lot of times what we see is opportunities for patient identification, but each market is a little bit different. And, across my 19 hospitals, I have hospitals that their largest referral source provides 17% of their admission source. And I have markets where they provide 80%. So each market it's very different. And I think at this point, it would be premature to put that in stone.
Kind of the chicken or the egg kind of situation where in your side, it's kind of premature. On our side, it's like we sort of want concrete evidence that can show you can support the volumes. Yeah.
Yeah, and I certainly respect, and what I would say is, we've opened 145 hospitals, 144 hospitals, and we have not had an issue where we've closed a hospital, and in fact, we are doing bed additions all the time because we underbuild hospitals in many markets. So this is all we do, and we've gotten pretty good at determining bed need and committing capital to help the patients in those communities get the care that they would otherwise not get.
Okay, just pushing this just a little further, I will say I do have some concerns. So given Danbury Hospital participating as an intervener, part of the New Vance system, 3 hospitals in Danbury, Norwalk, Sharon, accounting for about 35.5% of the 90% of your referral volumes, and they're stating that in opposition to the proposal. So it's, I'm not sure how likely that volume is going to come from them, and it's a large proportion of your projected volume. So I guess, how would you speak to that?
So again, in many markets, and I can give you specifics, Western Pennsylvania, our largest referral source at our Harmerville location, which operates with an ADC of 45, is a hospital, a UPMC hospital that has its own IRF unit. I think the comment was made earlier that a rising tide lifts all boats. And when we enter a market, we see not only the fulfillment of occupancy that we have projected, but we see an increase in the other providers in the market, just in the way that we market, in the way that we create and leverage our information systems and market data to target patient populations that are absolutely appropriate for inpatient rehab.
Okay. Thank you. Let's see. Next set of questions relate to sort of access to services within the region. And this has probably been answered, to some degree, but again, since it's a public hearing, just give me the general overall sense of how this proposal will improve access to inpatient rehab services in the area. Like specifically, will certain types of conditions be treated as part of your program that not readily available in the service area beyond sort of just the IRF designation?
So I can start with that, and Marty, Jennifer, if anyone else wants to chime in, you certainly can. But I think Attorney Chafin did a really good job of showing the overutilization of SNF, skilled nursing facilities in the state of Connecticut, and it is a completely different level of care that there's really not a lot of access to in Western Connecticut in the Danbury area. If you were to look at claims data and you were to look at how long, and one of the physicians from Danbury Hospital commented on this as well, about reducing length of stay. We help hospitals like Danbury take patients faster than skilled nursing facilities can. Not only that, those patients that come to us readmit significantly less than a skilled nursing facility that they're currently going to. Outside of that, because of that delay in care, Danbury Hospital or other acute care hospitals are saddled with cost of care when their reimbursement has stopped. And we help reduce those expenses by improving their throughput, reducing ER holds. And then the other piece is direct care to the patient. Aside from readmissions, if you look at the state of Connecticut, it's generally required that a skilled nursing facility would have 1.9 direct care hours per patient day. Our hospitals have almost 5 times that per patient day. We average around 6 hours of direct care hours per patient day from a nursing perspective, and 3 hours per patient day from a therapy perspective. We also typically have a full complement of medical staff. And in our experience, we have always been able to successfully procure that and build programs around the community's needs to deliver better outcomes for the patients. And I think we would help complement Danbury's service for the Danbury community that is currently underserved.
Okay.
May I add 2 things to that without
Sure.
reinventing the wheel? Okay. One is that in terms of specifically improving access, because my sense is you want more than just going back to the charts we've already talked about ad nauseum this morning. I would point you to CON page 245, where the Brain Injury Alliance Executive Director, who will speak this afternoon, actually says, and I quote, "Countless times over the years, Connecticut residents have been forced to get their care in Massachusetts or New York simply because there wasn't an appropriate place for them in Connecticut," end quote. So that's one comment. I recognize it's anecdotal and I don't have the volume, but we have boots on the ground, I believe was the phrase earlier, a provider saying patients are going out of the state to get the care because it's not available. The other
Hey, Brian, is this helpful?
Yes, sure.
Okay. I just want to, because the letter's in there and he's speaking, so we don't need to reiterate, but I'll I just want to let you know if this is going on and it's not helping, we can move on.
That's okay. She can finish.
Thank you. The only other point I would make that is not in the CON application is that there are Medicaid residents who are leaving Connecticut. So Connecticut Medicaid residents are traveling to Encompass, Massachusetts facilities today because of the lack of access of care. So I would use those 2 data points to address your question.
Okay, can you provide some form of evidence to support that assertion?
Yeah.
Yes, we will get you that.
You knew that was coming, right?
I did.
All right, late file 4. Medicaid beneficiaries and receiving care. Paid beneficiaries receiving IRF in mass. This is just kind of like a tangential question, just for my knowledge, or lack of knowledge, actually. How do you generally receive patients at Encompass's IRFs? How do they, and I know the referrals are coming from hospitals. Are they mostly like direct transport, like, medical transport from the hospital to your facility, or how do they get there?
It's either Pat. Can you answer that, Pat?
Typically, medical transport, ambulance.
All right, I think we've touched on this question quite a bit, but asking about how the new hospital would, it will affect existing providers in the service area. Danbury's perspective, it's going to be sort of harmful to them. You're saying it's more complementary service and it's not going to take patients away from Danbury Hospital's IRF. Can you comment on that?
Yeah, I can touch on that in a couple of different ways. So first, we've talked a lot about the rising tide lifts all boats theme, and I think the lack of rehab beds and the overutilization of skilled nursing patients. But so I don't want to repeat what I've already stated, but another thing that we do is we typically try to engage the dominant market provider in some agreements, such as we would purchase lab services, we would purchase radiology services. If we had to have a patient that needed a scheduled procedure, we would look to collaborate with Danbury Hospital on that. So there's revenue upside in addition to the cost control that exists when we move into a market. So from a physician component, if there is capacity, we would leverage medical and program directorships from the local community physicians. If that was purely tapped out, we would look to recruit physicians into the market. So there's a number of ways that we would work in complementary fashion. And again, as I've said before, we're kind of like Switzerland. We're an independent body. We would be an independent body here where we can service patients from all different kinds of referral sources. But if they had a need, Danbury Hospital is the closest hospital, and they would see benefit from that in the form of purchase services.
Okay. Just a question about payer mix. So 80% of your payer mix is basically Medicare patients. So approximately 12% will be commercial insurance, people covered by commercial insurance providers. Will these commercial patients be in network? Is it in network that you participate with, or out of network?
So that varies. In most of the time, it's an in-network benefit. In the event that it's not covered by insurance, we typically pursue a single case agreement that will cover the cost of care for that patient's stay. You cut out for me when you stated the percent of Medicare, but Medicare is the largest payer source for
80%.
Yeah, one thing that I think is important to note, and if you follow Becker's or Modern Healthcare or any of the major healthcare publications, is that has been a shift to Medicare Advantage programs, and I think that was alluded to in prior testimony today. And we have seen that, and we work really well with managed care companies and Medicare Advantage companies. In fact, we have grown our Medicare Advantage population in our hospitals by over 20% year over year. And we have really strong outcomes with that patient population.
Okay, thank you. This is something near and dear to our executive director's heart. Describe how you would be planning to promote health equity at this proposed facility in Danbury.
I think Dr. Charbonneau, if you're on, you can talk about that.
Yes, hi, can you guys hear me?
Yes.
Yeah.
So in terms of health equity, one thing that I think is important to point out is that the way that it works is that we get referrals from the care teams, the physicians, the discharge planners from these various acute hospitals. And when a patient needs rehabilitation, and we have systems in place, Medicare requires a rehabilitation physician to sign off on those referrals and attest to the fact that those patients are appropriate for our level of care for inpatient rehabilitation. The physicians who sign off on those referrals are agnostic to the type of insurance, race, religion, et cetera, sexual orientation. So it's just one thing. I know there has been some literature published about access to inpatient rehabilitation with certain minority populations. And I can assure you, and as a practicing physiatrist in our hospital for several decades, that we are agnostic to that information when we accept a patient. In addition to that, the company has invested quite a bit in improving awareness in terms of diversity, inclusion, and education of different minorities, sexual orientation, et cetera. So we have that training for all of our employees and our physicians as well. And that's something that we also are and our board of directors is also very committed to as well.
Okay, thank you, Dr. Charbonneau. Next set of questions related to quality. So you may be the right person that's to stay right seated.
Okay.
So describe the clinical quality measures utilized at other existing Encompass inpatient rehab facilities. Basically, what types of quality measures are used to evaluate IRFs?
Okay. How much time do we have?
High level.
A very high level view. So we have initiated metrics for all of our hospitals with various goals on quality metrics. So we follow things like acute care transfer rates, discharge to SNF, patient satisfaction. We have a program to ensure that patients are getting the correct type of prophylaxis against blood clots. We look at our medication reconciliation process. We have a huge project to reduce opioid prescribing. In fact, just this week, we presented at a national rehab conference a poster on our interdisciplinary approach to pain management in the inpatient rehabilitation setting. And since we initiated this program in 2018, we've had a dramatic reduction in opioid prescribing in our hospitals. And I'd be happy to share that poster with you if you're interested. So these are all metrics that we follow very closely, in addition to our usual quality reporting metrics that I'm sure that the unit at Danbury also is familiar with, that are required reporting metrics for Medicare.
Okay, thank you. And I was going to sort of follow up with, how does Encompass rate on those quality metrics, relative to standards, benchmarks and what have you?
We surpass all national expected goals. So we have both internal and external benchmarks that we follow. And I think our outcome metrics speak for themselves. We have last year an 80.3% discharge to the community rate. We use a net promoter score for patient satisfaction. I think our last quarter metric was about 67 or 66, which is very high if you're familiar with those kinds of data points. Also, as I mentioned previously in my statement, just briefly, we work very closely with the Joint Commission. All of our hospitals are Joint Commission certified, and we meet with the Joint Commission on a regular basis and are always lauded for our quality outcomes. We have a very robust infection control process, and we have disease-specific certification in many of our hospitals in different areas, depending on what the needs may be in that community. So most of our hospitals have disease-specific certification in stroke, but there's also orthopedic, pulmonary, amputee, spinal cord, traumatic brain injury. So when the hospital is established, depending on the needs of the community, and I think brain injury was mentioned previously, maybe in that area, getting a team that's really focused on brain injury, disease-specific certification would be helpful. And that would mean that you would have clinicians who have a specific interest and extra training in brain injury just to work on the brain injury unit with brain injury patients. So that's something that we can again, due to economies of scale, we don't have to reinvent the wheel. We have many of our hospitals with these different certifications and can help a new hospital get off the ground depending on what their interest is and what the need is in the area for that.
If I could just add one thing to bring that a little closer to Danbury. So our closest hospital is in Ludlow, Massachusetts. It's less than 2 hours away from you. And for the last 3 years, 82.9% of the patients that we have taken there have returned to the community. And what I think is really impressive about that is the UDS, Uniform Data Systems, gives you an expected number for what your patient population that you're serving, what they would expect you to return to the community. And the UDS expected for that 3-year period for the closest hospital to you is 74%, and we were at 82.92%. Under 9% for both discharge to skilled nursing facility and under 9% for acute care transfers back to an acute care hospital. And then that patient satisfaction number, that's actually a 200-point scale. So I think that's important to note. You can be negative 100 on that. So this facility is at 76.9, which is in the top 10 nationally for our hospitals.
Okay, thank you. So next follow-up, kind of related again to data, would be to provide us with Encompass, quality measure ratings for either, I don't know if you do it on a location basis, like or a system basis. You could do it for the 3 closest facilities. So quality measures, comparing what the facility did to, say, the benchmark for the last 3 years as a late file.
Certainly.
Sure, we can do that.
I think that's late file number, was it up to 5 here?
Thank you. Excuse me, Brian, but will we be able to go at the end of the hearing? Can we just go over these as a housekeeping matter to make sure I have exactly what you need?
Yeah,
Absolutely.
we'll do it at the end. Yeah.
Yeah, after everyone's done. Perfect.
Yep. Okay, moving on. Pre-filed testimony speaks to fact that Encompass utilizes an array of information tech to leverage best practices across the nation and enhance clinical outcomes. Several things were noted, like ACIT, the Clinical Information System, Beacon Management Reporting System, React and Sepsis, SIRS Alert, and Health Intent, a population health platform. I'm hoping to get just a little bit more information on how that technology works and how it improves clinical outcomes.
Okay, so you mentioned quite a few programs, but I'll just give you an overview. So in terms of our work with our partner for our electronic health record, which we internally call ACIT, Achieving Clinical Excellence Through Information Technology is the acronym. And we have worked with them and their data scientists to design predictive algorithms that help our clinicians with certain things. So one program is called REACT, and that program is geared towards reducing acute care transfers, REACT. So acute care transfers are patients who are in the rehabilitation hospital that need to go back to the acute care side for whatever reason. And what we did was we looked at our own data from multiple years, 80,000 patient encounters, and worked with the data scientists. And all of our patients are now receive a rating in terms of the risk of them being acutely transferred back to the hospital based on certain factors, labs, medication, changes in their appetite, their participation in therapy, et cetera. And we have incorporated this information into our electronic health record so that it is upfront for the clinicians to use on a ongoing basis. And so, for example, if a patient status changes from high risk to very high risk of being acutely transferred, the clinical team can reassess that patient and intervene accordingly, depending on what the metrics are that are changing, for example. So similarly, we have a predictive algorithm for evaluating patients at high risk of readmission to the hospital after discharge from our rehabilitation hospital. And that program allows the clinicians to make certain arrangements for those patients to reduce that risk of winding up back in the emergency room or back in the hospital after discharge. And those would be things like access to medications, communication with their primary care physician, making sure that the home health nurse gets there to see the patient the day of discharge, and follow-up calls. We call the patient the next day after they get home and a few days later to make sure things are going okay. So we have leveraged our own internal database, data warehouse, which is a huge amount of data right now, to be able to work with Cerner to design these algorithms to help with patient care. Currently, we're working on a fall risk algorithm, which will be a real game changer for inpatient rehabilitation in general, because the scale that's currently used to evaluate patients for fall risk was designed for patients in the acute care hospital, not in an inpatient rehabilitation setting, where our patients are different and they're moving around and they're going to the gym, et cetera. And they're all at a high fall risk to some extent. So we're excited about that. This is something that we're just in the process of rolling out. And our new hospitals coming on board get training and get all of these resources when they open their doors. And we train our clinicians in terms of how to use these resources to improve clinical outcomes. I can't hear you. You're on mute.
Thank you. I've been doing that a lot today, huh? On Exhibit O, Bates, page 581, Encompass states that you discharge a higher percentage of patients, 79%, to the community compared to nursing homes, which is, you list 40%. Was the 79% for any specific type of treatment, like hip fracture, patients, or was it for services across the board?
This is
Speak to the
Marty.
numbers. Go ahead, Marty.
Sorry, the data is for all Encompass patients, so all patient types. It's not specific to any one diagnosis. It's across the board.
Okay, and I didn't see any data to sort of support that assertion. So can you provide me with a specific discharge status for patients to validate that 79% to the community?
Yes, you're pointing out that I missed my footnote on that. So I owe you a footnote on that. And I apologize. We'll get that to you.
Okay. Just one further question about sort of discharges in general. How do you, what's the sort of your protocol for discharging patients after they complete their rehab?
So
Charbonnet?
the way, yes. So basically the way that it works is that we work with the patient and the family when they first get in terms of what their goals are for discharge. And then as the patient progresses towards those discharge goals, we have conversations with the patient and the family about appropriate discharge arrangements, depending on what their needs are, where they're going, and so forth. So the discharge date is something that gets discussed and communicated with the team, the patient, and the family, and gets set accordingly. And we have programs in place to ensure a good transition of care. So we know that patients are at highest risk of readmission to a hospital when they go through a transition of care. And the highest risk is when patients go from a hospital to the home environment. So that brings into play all of our programs that we have on discharge, medication reconciliation, making sure patients and their family understand their medication, have access to their medication, and that we have arranged appropriate follow-up with their primary care physician or whatever other physicians they need to see, and so forth. So that's how the discharges are planned well in advance.
Okay, thank you. So last question on quality. Your testimony, Exhibit O, page 687, states that studies have shown that patients receiving SNF rather than IRF care had higher mortality, more readmissions and ER visits, and ultimately more days in the hospital. Can you explain, why IRF care is different and helps to lower those things? And if there's any evidence or supporting studies that can confirm, lower mortality, fewer readmissions, and ER visits between the two?
Yeah, so I think that the major difference is the medical oversight and attention that patients get in the IRF setting. And in fact, in 2016, the American Heart Association, American Stroke Association published clinical practice guidelines specifically stating that patients who have had a stroke who need rehabilitation are best served in an inpatient rehabilitation environment because the studies do show reduced mortality and morbidity and better functional outcomes for those patients. And there are many studies that look at that sort of thing, and we'd be happy to provide you with some references.
Okay, great. That would be great. So I'll put that down as late file 7, studies confirming reduced mortality, lower readmissions and ER visits in IRFs compared to SNFs. Okay. Thank you.
If I may just add one point to that, and everybody I'm sure is aware of how patients who were in the nursing home environment did when COVID reached our shores, and we all are familiar with the tragedies that ensued in the nursing home environment for many of these elderly, vulnerable patients. So I think that just has highlighted the differences in terms of infection control and training of staff and medical oversight, et cetera, across the country. I'm not picking on Connecticut by any means, but across the country, it was just kind of a startling contrast.
Yes, very sad. Thank you. Those are my questions. I'm going to pass it along to Ormond.
Yeah, I know Ormond is next. I just, Leslie, how many, I hope you don't mind me asking you this, how many do we have to sign up? And if they're here, we can take them. I know that some of the public might just be calling in for, or to do their comment, and I know we can take it out of order. But I know Ormond has some important questions and we have legal arguments still. So anyhow, Leslie, how many, can you send me the list?
Sure, we have four, and if you want to start, Mayor Cavo is here.
Okay, Mayor
City of
Cabo, are
Danbury.
you present?
I am.
Okay, I'm going to start with you, but I'm going to just put a little intro. So I am taking this, I am doing a little break in the Office of Healthcare, Office of Health Strategy questioning to take the public comment. For anybody who took a longer break, I'll just check again before we close to see if there's any, Leslie, just remind me, just if there's someone that maybe tuned out and is planning on coming back, we will take their testimony, but I don't want to make the public wait any longer. So I just want to give you a little instructions before we start with the mayor. So we will call the names of those who have signed up to speak in the order in which they are registered. If we miss anyone, please utilize and raise your hand. Speaking time is limited to 3 minutes. Please do not be dismayed if we stop you at the conclusion of your time. We want to make sure that we give everyone the opportunity to speak, and we want to be fair. Additionally, we strongly encourage you to submit any further written comments to OHS by email or mail no later than 1 week from today. Our contact information is on our website and on the public information sheet, which you were provided at the beginning of this hearing. Thank you for taking the time to be here today and for your cooperation. All your statements are very important to us. We do consider them and sometimes even do follow-up questions based on what we hear from the public. You are limited to 3 minutes, and Mayor, go ahead.
Thank you.
But
Ms.
please, and I'm
Antonelli.
going to have you identify yourself and spell. We have a court reporter. This is all being transcribed. So if you would also just spell your name for the record, please.
Sure. Thank you, Ms. Yandel, and thank you to everybody for having me here today. My name is Mayor Joe Cavo, C-A-V-O, and I am currently the mayor of the city of Danbury and a graduate of a speed reading class. So we should be in great shape here in 3 minutes. So thank you very much. As mayor of the city of Danbury and a 35-year resident, I am proud and honored to provide this letter in support for the proposed new freestanding comprehensive inpatient rehabilitation hospital to be built within our city. Having previously been a member of the Danbury City Council for 17 years, 15 of those as the president, I have been very involved and committed to the ongoing growth and development in the greater Danbury community. The provision of high quality comprehensive healthcare services is of paramount importance to meet the needs and the expectations of our citizens, particularly those who will greatly benefit from advanced and intense physical inpatient rehabilitation. Encompass Healthcare is a nationally known and respected inpatient rehabilitation hospital, providing 137 rehabilitation hospitals across the US and Puerto Rico, brings tremendous experience and expertise to our community. In addition to the benefit for patients suffering from strokes, traumatic and non-traumatic brain injuries, orthopedic trauma, hip fractures, spinal cord injuries, and many other conditions, Encompass Rehabilitation Hospital of Danbury, LLC, brings significant economic benefits to our region. This $39 million investment in land, building, and equipment, along with the provision of long-term tax revenues, over 100 construction jobs, and 80 to 130 new employment opportunities to staff the new hospital, brings great economic growth to our city. I echo former Mayor Boughton's previously submitted letter of support regarding Danbury and the neighboring cities in the planning region of Western Connecticut's tremendous advancement and growth in all of the commercial and healthcare sectors. We have become a very desirable location to live and work, as evidenced by the year-over-year population growth in this area. We work diligently on a local and state level to anticipate and project the infrastructure needs and the support for all of our residents now and into the future. Convenient, cost-effective, and quality access to comprehensive healthcare services is critically important to serve all of our citizens. Currently, there is a gap in the care for many of those patients who would benefit from comprehensive inpatient rehabilitation, as evidenced by the very low inpatient rehabilitation utilization rate in our region and our state as compared to other parts of the country. We are fortunate to have Danbury Hospital's Rehabilitation Unit as one resource for such services, And I believe Encompass Health Rehabilitation Hospital of Danbury LLC will only complement their program rather than compete. This will allow for more rehab appropriate patients to access the needed care and therapy within our community rather than travel long distances or even out of state to obtain their needed comprehensive inpatient rehabilitative therapy and medical care. We look forward to this proposed addition in the new freestanding Encompass Rehabilitation Hospital of Danbury LLC in our community. I highly support and encourage your approval of the certificate of need request on behalf of the citizens in the Danbury and the surrounding areas. Thank you very much for your time today.
Thank you, Mayor. And again, I apologize for the wait, your wait and the wait for anyone else in the public. OHS takes everything under consideration. We listen to public comment, and it's very important that we take all the evidence. So I do apologize for the wait, but I want you to know that it's because this matter is very important to us. We want to make sure we take in all the evidence in a very orderly way.
Not a problem, and I understand, and I thank you for the time, and not a problem here. Thank you.
Okay. Thank you. Next on our list is Dr. Bueno. Is Dr. Bueno available?
Yes, I am. It's Earl, E-A-R-L, Bueno, B-U-E-N-O. Good afternoon. I'm an anesthesiologist at Waterbury Hospital. I've been involved as a patient and provider advocate over the past decade as chief of anesthesia, a member of the hospital staff executive committee, and the immediate past president of the Connecticut State Society of Anesthesiologists. Also, as chair of utilization and peer review of a regional independent physicians association, also known as an IPA, I'm experienced in issues regarding prolonged hospitalizations and readmissions from extended care facilities. The impact on patient care and healthcare costs are quite significant when optimal care is not available. There's a multitude of reasons for prolongation of care, ranging from surgical site infections to blood clots, known as deep vein thromboses or DVT, that may even lead to life-threatening pulmonary embolism or PE. This affects not just post-surgical patients, but also those being discharged after strokes, heart attacks, traumas, and infections. There's a great variability in the quality of care among different rehabilitation facilities throughout our region, and that is one contributory factor in so many different outcomes. Oftentimes, physicians have minimal input regarding which facility to which their patients will be discharged. Rehabilitation services, including physical, occupational speech therapy, promote faster recovery, allowing patients to return to their home environment as soon as possible. Patients benefit from a high-care, multidisciplinary inpatient rehab facility such as Encompass Rehabilitation, one that can reduce the risk of complications and decrease the length of stay. In doing so, better outcomes can be expected and the cost of care will be significantly reduced. I support the establishment of facilities such as Encompass Rehabilitation, which focus their skill set on this patient population. Currently, the patients and their families have to travel significant distances to receive this degree of inpatient rehabilitation, since there's a limited availability of these beds in Western Connecticut. It serves our community a greater good to have access to this level of care locally. Thank you for your time.
Thank you. Julie Peters.
Good
Hello.
afternoon. Hi.
If you could just state and spell your last name for the record, please.
Sure.
In 3
My
minutes.
name is Julie Peters. That's P-E-T-E-R-S, and I'm the Executive Director of the Brain Injury Alliance of Connecticut, which has advocated on behalf of individuals with brain injury and their caregivers for 40 years. I'm here to express my support for Encompass Health Certificate of Need application to build an acute inpatient rehabilitation hospital in Danbury. At BIAC, as part of our mission, we advocate for accessibility and availability of inpatient rehabilitation for residents of Connecticut with brain injury. We work with individuals who sustain brain injuries to support navigation through the complex medical, rehabilitation, social, financial, vocational, and educational outcomes after acquired brain injury. For the past 19 years, as I've worked in Connecticut as the executive director, I have seen the challenges we face as a result of having so few acute inpatient rehab hospitals in our state, particularly in Western Connecticut. And I'm speaking here particularly for people with brain injuries. There is virtually no competition for individuals with brain injuries in our state. Countless times over the years, Connecticut residents with brain injury have been forced to get their care in Massachusetts or New York simply because there wasn't an appropriate place for them in Connecticut. I've seen families who either have to move to another state temporarily or not have daily connection with their loved ones. Individuals forced to go out of Connecticut to receive care also lose the access to their local network of both medical and social support. There's a dire need in the state for more rehab facilities in order to allow individuals with brain injury to get care as close to their home environment as possible. Comprehensive inpatient rehabilitation hospitals such as Encompass provide a much higher level and intensity of rehab and medical care not found in other settings such as SNFs. And I can't tell you how thrilled I was to hear Dr. Charbonneau talk about the importance of specific brain injury education and training when dealing with individuals with brain injury. SNFs just don't have that in Connecticut, and they don't have that level of care. So this gives individuals with brain injury the best possible opportunity to achieve better outcomes. Individuals with brain injury who have access to intensive physical, occupational, and speech therapies will result in lower lengths of stay, improved functionality, returning faster to activities of daily living, inclusion of family participation in their rehabilitation, and a wide range of rehabilitative and social benefits. Brain injuries like ours throughout the country have developed and depend on positive relationships with comprehensive inpatient rehabilitation hospitals, and Encompass Health is well known for their expertise. And I would say we would be another one of those who generate referrals for Encompass Health through our helpline. We look forward to welcoming Encompass Health to Danbury and Western Connecticut. For these reasons, I hope you will seriously consider the granting of a certificate of need for an acute inpatient rehab hospital in this region. It would provide a much needed service to individuals like those we serve every day, as well as to the larger community. Thank you.
Thank you very much. Dr. Janet Gangaway.
Good afternoon. My name is Dr. Janet Gangaway. Last name is spelled G.
Can you put your camera on?
Sorry, I
Thank you.
managed to unmute and forgot to put my camera on.
That's okay.
I'm Dr. Janet Gangaway. Last name spelled Gangaway. Thank you for allowing me to speak today. I have a doctorate in physical therapy and board certification in orthopedic physical therapy. After 6 years of practice, I have spent the last 20 years in academia, 15 years in a doctor of physical therapy program, and the past 5 years in the Connecticut State Colleges and Universities system as program director for the Physical Therapist Assistant Program at Naugatuck Valley Community College. We educate physical therapist assistants and prepare them for entry-level practice in the field of physical therapy across multiple settings. This includes both content and clinical education experience across the breadth and depth of physical therapy practice. Acute rehabilitation is one of these areas. An acute comprehensive inpatient rehabilitation hospital provides intensive therapy using state-of-the-art technologies. This unique setting provides our students with the exposure and experiences with patients who are acutely ill or experience significant trauma. The demand for these services is on the rise, especially due to the long-term effects of the COVID-19 infection. To have workers prepared to enter the workforce, including physical therapist assistants, respiratory therapists, and nurses, facilities must be available to provide the necessary clinical education experiences to our students. The availability of acute inpatient rehabilitation for our students is very limited, despite there being a number of rehabilitation hospitals more to the east of Connecticut, since we are located in Waterbury. As we've all heard several times, there is a wide variety of patients who need inpatient rehabilitation: stroke, neurological disorders, multi-trauma, traumatic brain injury, amputation, neuromuscular conditions, just to name a few. Rehabilitation services, including physical, occupational, and speech therapy, enable faster recovery after brain injury and other conditions to allow patients to return to their home environment as soon as possible. Patients receive 3 hours of therapy per day and achieve far better outcomes than those received in a lower level of care setting. Acute comprehensive rehab hospital and services are very limited in Western Connecticut. resulting in patients and families having to drive long distances to receive their level of care that they need. It also limits the family's ability to visit and participate in their care. This proposed hospital will greatly benefit patients from throughout Western Connecticut. It's vital for us to be able to train our students to be as prepared as possible for the workforce that they are about to enter, and this hospital will help meet that need. I greatly support this project and encourage your approval for Encompass Rehab Hospital of Danbury. Thank you for your time.
Thank you for your time. And thank you for your words.
You're welcome.
That is the last. Is there any other participant that's online with us here that believes that they signed up to make public comment? So that's the end of the list I have. Leslie, do email me if or send me a message if someone else signs up. We have taken this out of order, so I just want to make sure we don't miss anyone that wanted to speak. So I apologize, Orman, for disrupting the question flow, but you can go right ahead.
Good afternoon. My name is Ormand Clark, spelled ORMAND-CLARKE. I'm a healthcare analyst at OHS. My initial round of questions are in relation to cost to consumer. Throughout the application, you state that Encompass has comparatively low cost and provides cost-effective care. Kindly discuss how Encompass can provide lower cost of care.
Yeah, this is Marty Chapin. I would refer you, I guess, to Exhibit G in my pre-filed testimony. And I would talk first about the lower cost of care at Encompass compared to other Irfs. And when you look at this chart, you see that, and again, this is national data, but based on Encompass experience, they have lower cost and lower payment per discharge. What that translates into is less cost to the healthcare payers and to the patients and their families. And that's relative to other Irfs. Does that answer your questions? Because some of that lower cost is the efficiencies that like Pat could speak to, some of the efficiencies that they have as a national company.
So I can expand on this a little bit. And, you know, if you look at it from a siloed point of view, just from a per case level, inpatient rehab is more expensive than a skilled nursing facility stay. That is a fact, but we readmit patients significantly less, and that has monetary considerations to it. So we reduce future downstream episodes of care. The fact that we're able to get, 82% of our patients at the closest facility to you, home, and not to a skilled nursing facility less than 10% of the time, that reduces costs from an episodic cost of care perspective. And then I talked a little bit about the costs when reimbursement has stopped and a patient is beyond their geometric mean length of stay, which Medicare defines as typically the average amount of time a patient would stay in a hospital for a particular diagnosis. In most hospitals, that amounts to several $1 million a year. And you can arrive at that by looking at their direct cost per day, multiplying that by the days over the geometric mean length of stay. So, from an episodic standpoint, when you factor all of those things in, we are a cost-effective site of care.
And Mr. Theo, as a follow-up question, kindly explain how the cost of care at Encompass, this proposed facility, would be lower than existing facilities in the state of Connecticut.
So if you're talking about existing Irf beds. The exhibit that Marty had mentioned, so hospital-based distinct part units on average are paid more from payers, whether that's Medicare or commercial payers than we are. And as a result of that, from a direct cost perspective in our level of care, we, because we're able to centralize things with the use of our systems, salaries and wages are typically one of the most expensive parts of healthcare. And because we're able to have those efficiencies, we're able to save costs on from that standpoint. Marty, I don't know if there's anything you'd like to add to that.
Yes, the one thing I would add, very specific in terms of Connecticut, is in the rebuttal testimony, my rebuttal pre-filed testimony that was sent last night. I don't know, Orman, if you've had a chance to see that. But in that, there's a table that gives you specifically a comparison of Danbury Hospital versus Encompass Hospital's proposed charges. And to get in the weeds for just a second, Encompass Danbury's proposed charge per patient discharge is over $3,700 less than what the cost is to Danbury Hospital. So when you ask specifically about Connecticut cost comparison, hopefully that addresses your question.
Thank you. If we need additional information, we will get back to you.
Okay.
Excuse me, this is Brian. Can I just follow up one question on that chart you were talking about, exhibit DD, page 5. So you have you have charges per patient day, you have charges per discharge. Okay, get that. And you have charges again. I'm thinking that's total charges, or I'm not sure what that represents. One says, is that just total volume?
It is. You're pointing out all the things that I thought were clear that are not, and I do apologize. Okay. Yes, this was the total charge amount, so that then you could check our math and see our source document of total charges divided by the patient day gives you the charges per patient day, just like the total charges divided by the discharges gives you the charge per discharge. And if it helps you, we can send you the AHD report. I don't know if you have access to that or not. It's a subscription based.
Yeah, we wouldn't have access to that.
Would it help to see it? Source
Absolutely, it would.
Okay.
Sorry, Armand, you can continue.
What late file are we up to now? I think I've.
It might be 8 or 9.
8. I have 8.
Okay, so okay, Armand, thank you.
Okay. And describe the different care settings and how the costs differ between those and the proposed IP rehab facility.
Yes, in doing so, I would refer you to Exhibit G, page 3, because that's a good point when you're asking about each setting and how it differs. If we look just at the cost per day, for example, inpatient rehab will be higher than a skilled nursing facility cost because CMS bases their payment, and the cost also is based on resource utilization. So inpatient rehab, for example, per day is $1,689. So it's higher per day relative to the skilled nursing facility cost per day. But two things I would ask you to consider. One is that the length of stay in those two settings varies greatly. So while a per day basis in the skilled nursing facility is lower, on average, the residents stay in a skilled nursing facility more than twice as long. And so that means conversely, while Irf, the charges and the costs are higher, the patients are in and out quicker. It's a 12-day length of stay versus almost a month length of stay.
Thank you.
Does that help?
Thanks. Okay, thank you. My next round of questions are in relation to demonstration of financial feasibility, and these I will direct to Mr. Teo. Your testimony indicates that the proposal will cost approximately $39 million. Please discuss Encompass's plan and ability to fund this project.
Thanks for the question. And we also have a member of our development team, Mr. Bill Heath, who may be able to provide some information on this as well. Mr. Heath, I don't know if you want to take that first or if you want me to take it.
If there's going to be another witness, I'll need to swear him in.
Do you want to answer?
I'm not sure. Yeah.
I mean, are you okay with doing it?
Yeah. I'm sure.
Yeah. He's sworn in.
Okay, please raise your right hand. You solemnly swear that the testimony you're about to give in this matter is the truth, the whole truth, and nothing but the truth to help you God?
I do.
Please state your name for the record and spell your first and last name, please.
Sure. It's Bill Heath, Heath.
Okay, Bill, Bill. Okay.
Yes, sorry.
Just your name doesn't come up on, so that the court reporter knows how to do it. I'm just assuming, so.
Yeah, you got it.
So, Armand, whoever you want to ask the question of, I guess that you can, Mr. Keefe, I think is being identified as their financial person.
Sure. So I'll say very quickly a couple of ways we can do that. I know in other CON states, we have provided a letter by someone in our finance department testifying that we have the cash available to pay for it. Certainly we could get that if that's something that would be, yeah.
That would help.
I think we included a copy of our 10K as well, that I can't speak off the top of my head exactly what the cash flow from operations is, but I can tell you we're very busy on the development front. We have opened 8 new hospitals this year, anticipate opening at least that many next year and the following year. We have sufficient cash flow to fund all of this. We're not.
Okay, and whatever you can submit to proof. I think you know, his question was specific to this facility, this proposed facility. So if you could, we would have a late file then to support. What is it exactly, Orman, that we should be getting? We want some sort of financial statement or financial records regarding that they have the funds.
Yes, the availability of funds to create this facility.
Yeah, and what we can do is, I mean, 2 things. We can get a funding letter from the Encompass CFO, which will confirm what we put in our hearing issues response. There was a question about financial feasibility, and the last portion of that, I don't have it in front of me, was sort of the substance of what would go into a funding letter to be signed by the chief financial officer of the company. So we can get you that. And then the 10K is already in the record, and we can look at that a little more carefully and point you to where in that 10K it would show cash flows and sufficient cash to fund the project. So those are 2 ways I can think of to do it.
Oh, we have.
We have, if it helps, because I know it's such a voluminous CON application, we actually have a funding letter from the senior vice president and treasurer confirming the ability to fund the project.
And that's on page 82 of the original CON submission. I didn't realize that was in there. That's what I was offering up.
Yes.
And then just to follow up about that, is it still relevant? Like, does it have a time frame, or I know a lot of time has passed, so
it doesn't, because it's internal, but I'm happy to get you a fresh one, a newer one. That's fine.
Okay.
It's
yeah, I think that would be a good idea. Just a lot of time has passed.
Yeah, it's from April 2020, so I'll get you a new one.
Okay, thank you.
And then Mr. Clark, Mr. Carney, are you done? I didn't want to.
Yes, I am. Thank you.
No problem. And then Mr. Clark, so once the project is funded, which we can provide that information to you, operationally, how that is funded going forward is And there was an exhibit, I don't have the reference for it, but that same exhibit that I was talking about that shows our average cost and our average reimbursement, you can see that there is a profitable margin there. And that is through our cost-effective care and appropriate management of patients, very similar to what Danbury Hospital is likely doing in their inpatient rehab hospital or unit.
Thank you. Mr. Tior, if volumes are below projections, how will this affect Encompass's ability to operate the program?
So the and if anyone from the Encompass side wishes to jump in, feel free. But we have the ability to, if this hospital, you say we were under projected on volume, we have the financial capacity to cover the costs of this hospital operationally, and that funding letter will help provide that information. But we, as I said, in our 144 hospitals that we've built or acquired, we have none that are not profitable. And but we do have hospitals that are not at their volume projections that we establish on an annual basis from a budgetary perspective. And we work with the hospitals. So I'm the regional president, but I have subject matter experts in nursing, in therapy, in care coordination, in business development, and patient education and identification, that if we're not where our volumes were expected to be, that we work to identify the issue. Is it an outcome issue, which is typically not the case, but is there a frustration from a local referral source over perception of outcomes? And we would work to with that referral source to remediate any concerns, and typically from that, if there is a bed need, such as there is in the Danbury market, then typically the volume issues subside. If you have a bed need and you provide a great service with great patient satisfaction, great discharge outcomes, and you're a good partner for the acute care hospitals in your market, like Danbury Hospital, the volume comes. And across 144 hospitals, we have not had that not be the case.
Let me add briefly, I know it's late in the day, let me add briefly, we have a lot of information that has been filed. So Mr. Clark, one thing that we did, it's on CON page 715 to cut to the chase. If the volume is not met that we projected for year 3, which was 900 and some odd, 963 admissions, the break-even number is 524. So significantly lower than our projections, and this facility is break even. There's no loss of money there. So the facility could actually operate at a 46% occupancy and not lose money. I don't know if that helps address your concern or question.
Yeah, my succeeding question was intended to be and directed to you as well. What was the volume of patients needed for break even?
We're on the same page.
Yeah, good.
Marty, thanks for being much more succinct with your response than I was. I appreciate that.
Thank you. I have a few questions for Dr. Aronson. Dr. Aronson?
Yep.
Yes.
Yeah. What impact will this proposal have on Danbury Hospital?
I think it can have a significant impact.
Is there a camera available?
Yep, we're working on it. 1 second. Can you hear me?
Yes.
Okay. I think it can have a significant impact. There are major Medicare rules that we have to abide by. One of the rules I mentioned before in my testimony is regarding the 60% rule, where we have to have 60% of our patients with one of 13 medical conditions or neurologic conditions. And if another rehab hospital is taking patients away from us, it could potentially reduce those number of conditions that we're treating and potentially put us at risk at not being compliant with Medicare guidelines. So that's one way. The other way is, having a brand new facility is always going to potentially be a lure for patients, regardless of quality. We've seen that with extended care facilities in the past. Things that open up that are brand spanking new are going to be certainly a form of attraction, but quality is what counts. And the quality of care at Danbury is beyond none.
And what types of rehab services are offered at Danbury Hospital? For instance, are they comparable to what Encompass is proposing?
They are comparable. We are intensive level rehabilitation. So we are not a freestanding rehab hospital. So we are within the hospital setting. We offer the same degree of intensive rehabilitation. We deal with the same types of patients. We're just smaller, but we also take very medically complex patients that the surgeons and the physicians still need to follow very closely. That's one of the reasons they don't oftentimes get approved to leave the hospital. So as a result, they come to our rehab unit where these doctors can still follow the patients very closely.
And we have learned since morning and previously before that there are 14 inpatient rehab beds at Danbury. But of these available beds, how many are currently being staffed?
At the present time, it depends on our census. Right now, it's staffed fully because we have a higher census today. But it depends on how full the census is. So the nursing manager is very good at adjusting how many actual PCTs and nurses are available depending on our staffing of the day. So we do what would be considered our huddle and let them know how many admissions we're doing. And based on that, they determine what type of staffing ratio they need.
And can you give us an idea of how many patients can be treated in a given year?
I believe we discharge like 370 patients, something along those lines. I don't know the exact number. We can get that for you. The other competitive issue is that there is a staffing shortage, particularly for nursing and medical assistants, and we face it every day, both in our offices and in the hospital setting. So a rehab hospital coming to this environment would potentially pull staff from us, which would be really detrimental.
And do you have knowledge of patients being denied services or discharged prematurely due to capacity limits at Danbury Hospital?
No, if it happens, it's extremely rare.
Can you provide a circumstance that might happen?
Again, it's rare. On rare occasion, they might go to Gaylord because of specialty care there, but it would be unusual.
So this is Brian, just a quick follow-up, doctor. So today you said your census is full at 14 beds. If someone else, there was a need for an additional person coming over today, they wouldn't be able to get admitted, correct?
No, that's not correct. We have a very kind of revolving door. So tomorrow we have 2 discharges, Saturday we have 1 discharge. So it's very dynamic in terms of the process.
Okay, but just say you got a call today and someone was looking for an inpatient rehab bed. So you'd have to wait till you discharge one to admit them, correct? Or
if we're at capacity, when we're full, that's,
yeah,
doesn't happen all the time.
Okay, thank you.
Okay.
And that's another reason why that's another reason why we would consider in the future expanding if indeed that were to happen on a very consistent basis.
So how often are you at capacity? I mean, has it happened?
It's happened. It's not that often. We have.
So what does that mean now? I just don't know what that, like, does it happen once a month, once a year? What does that mean?
I would say once every few months.
Okay, thank you.
One more follow-up, doctor. Are you guys taking patients from Sharon and Norwalk hospitals as well in your program? I'm guessing.
We we are always available to take patients from most hospitals that refer, or all hospitals that refer. Norwalk Hospital, we screen these patients because their case managers are very assertive in sending us referrals. What happens is the patients, we approve them, and then they actually decline the offer because geographically we are far from them, and it's about a 45-minute ride. So they oftentimes will select Stanford Hospital instead of us, despite us being in the New Van.
Affiliation. That's
Exactly.
interesting.
And also, we have neurosurgeons who actually cared for the patients and encouraged them to come, and some indeed do, and it's great because then they have the continuity of care from the neurosurgeon who treated them. But nonetheless, it's their decision. Honestly, we obviously respect that, but is it in their best interest? Not necessarily, because their surgeon would be here.
Thank you.
Can I just follow up, because you opened up a nice, I think Brian and I both have like some questions, and this is a good line of questioning. So, I mean, is there a time where somebody said, oh, you have the option to get your therapy at home versus going in, an inpatient? I mean, how often does that happen? And what, just from your experience at Danbury, what do patients prefer? I mean, I don't know. So if you could, if someone's an inpatient, does it mean they shouldn't be at home? Is that why they're inpatient?
There are instances where patients are better served being at home. Perhaps someone with dementia might do better in their home environment, but that's extremely taxing on the family unit. They would have to probably hire additional care or have hands-on care that they would have to deliver themselves. So it really depends on the scenario. We don't oftentimes recommend it, but we can help gear the families up for that type of discharge if it indeed is appropriate. A case, for example, might be if someone has an end-stage condition and really can't do the intensive rehabilitation, or the quality of life needs to be optimized. You might want to set them up for home care, or they're too high level. Let's say they're a cardiac patient who doesn't need oxygen anymore, can walk 75 feet, but just need someone to maybe put a hands on them just to make sure they don't lose their balance. That's someone who might be able to train a family member, get some home care services in. They don't need the intensity anymore because they're medically stable and functionally they're doing quite well. Just a little support at home would be very appropriate and a good use of our Medicare dollars.
So, talking about the Medicare dollars versus, the stay in the hospital versus a stay in a facility like Encompass. So we heard from Encompass that their argument that Encompass will save money. I mean, do you have a position regarding that?
Hard to say. I think that, we can look at the statistics they have from around the nation. From what I see from patients having to be readmitted back, whether it be from other hospitals, which indeed does happen, even from large university settings, that those are costly patients. They're sicker patients. The tendency for those patients to be readmitted is high. So that drives up costs. So it's hard to say.
Okay, thank you.
Thank you. What would be the typical discharge plan be like for a patient leaving Danbury Hospital Rehab?
Very often, we will, depending on their functional level at the time of discharge, we aim for as highest functional level as possible, which means independent or modified independent, meaning you're sent home safe, but with an assisted device. Very often, we really like to use the continuum of care. We want to make sure that they're really comfortable and safe in their home environment. So we will most of the time recommend home health care. That means a visiting nurse coming in, a nurse to check medications and medical stability and pass off care to the primary care doctor. So there's that continuity. Then the nurse reports back to the primary care doctor any changes. Also then a PT and OT or speech or all three complemented therapies would be then in place depending on the patient's needs. If a patient's really high level and you feel the best place for them to get more aggressive outpatient care, then we send them to an outpatient rehabilitation facility. That's where they can still get more access to different types of equipment, a little bit more focused type therapy rather than the home environment. You have specialized equipment, you have a little bit more dedicated neurologic therapists working with these patients. And that would be another way of discharging a patient depending on their needs.
Can I just ask one further question, Doctor? What can you tell us about your plans for expansion of services at the hospital?
So that's something we've been looking at intermittently. When we became a new Vance Health System, we thought there might be opportunity in the future. We did look at, was there room to make some beds on our current rehab unit? And we explored that. We didn't put the dollars in per se at that time, but we said, yes, we have the capability. Yes, we would potentially budget for it. Certainly there's money allocated for it as well. We just needed to get a sense what would happen as a system. Again, when Norwalk Hospital closed their rehab unit and we became more aligned with them, we thought there'd be a potential for more referrals coming from them. We get about one patient a month from Norwalk Hospital as it stands now. That potentially will grow once we have a screener in place who will be working closely with the doctors, the case managers, and that potentially will grow. So we don't know what that will yield. So again, that's a potential growth phase that we are trying to accommodate for, both from a physical layout standpoint, a budgetary standpoint as well.
Thank you.
Thank you. What are your current volumes for inpatient rehab at Danbury Hospital? Would you know?
Per year?
Yes.
I don't have the number off the top of my head. I think.
Would you be able to provide that for us?
Sure.
Thank you. And what is the average daily rate of inpatient rehabilitation?
No rate. You're talking about cost?
Yes.
We'll provide that. I don't want to misquote that. I have a general sense, but I think we should provide that in great detail.
Well, and when you do, kindly provide for per commercially insured as well as self-pay patient, please.
Absolutely, absolutely.
Thank you. And that concludes those conclude my questions. Thank you so much.
Thank you.
Brian, did you have any more follow-up questions?
I'm good, Attorney Ando.
Okay. Attorney Fusco, do you have cross on any of this? Attorney Fusco?
Sorry, I'm having a lot of trouble with the muting. It's been a long day. No, we don't have any questions.
You don't have any questions. Okay, and Attorney Tucci, I don't really need any more cross-examination from you unless you can identify something that you think you want to, would be, we know how to go pick through the evidence. Is there anything you want to bring to my attention regarding what you would, you're on mute.
No, can you hear me now?
I can.
Yeah, the answer is no, we have no follow-up questions.
Okay.
Thank you for the opportunity.
Okay, good, you're welcome. All right, we're gonna have closing arguments now, but before we do that, Armin, do you have the list of the late files we'll go over? I know, hopefully they were getting a little, I don't even know what number we ended at. You're on mute.
I will finalize that in a moment.
Okay, you can finally, okay, so we'll go over those at the end of the hearing then. So I want to then move on to closing arguments. I'm going to, Attorney Fusco, I'm going to start with you. I'm going to, if you could try to keep it to 5 minutes, if you have, more than that, I'll let you go. But and I'll also let you have the last word. I'm going to then, go to Attorney Tucci, and then I'll come back to you for another. You can have the last word. This is your application for, if you want, for another minute or something. But why don't you go ahead? Do you have a closing argument?
I do, and I think I could definitely keep it to 5 minutes. I just wanted to start by thanking you, Attorney Ando, and members of the OHS staff. I know how challenging these remote hearings are. I've now done 4 or 5 of them over the last year. I feel like I'm impressed with how well you guys have have worked through these and kept them orderly and you know, gotten a lot of information in a short period of time while still accommodating the public and witnesses and attorneys all over the place. So thank you very much again. It's been a long day of testimony and questions and comments. And so I'd just like to take maybe a few minutes to level set and to remind OHS what the proposal is about and why, you know, this critically important project should be approved. And I'm just going to try to hit briefly on some of the key CON decision criteria. So, you know, as you know, much of the testimony and questions today is focused on whether there's a clear public need for the 40-bed IRF proposed by Encompass. Those who oppose the CON say there isn't, right? They point to the state healthcare facilities and services plan and say that it shows, you know, a minimal need for additional rehab beds in the state. However, as you heard from Ms. Chapin, the state health plan need methodology relies only on historic utilization and population growth going forward, and it doesn't account for those patients in need of rehabilitative care and services who are currently receiving them in, you know, less than optimal care settings like SNFs. I know we've talked about this a lot today, or who are foregoing needed rehab services altogether. You know, on the other hand, if you look at the data-driven population-based needs methodology used by Encompass Danbury, which is Ms. Chapin has told you uses publicly verifiable Medicare data that we're going to provide to you. It does show that there's a significant unmet need for inpatient rehab services in the area, the gap in care that Marty's talked about. And so this proposal, if approved, is going to increase access to needed healthcare services for the target patient population, which are these patients who need IRF services and are not getting IRF services due to a lack of beds in the area. I think the applicant's also shown, and we're going to submit some additional information to show that, you know, based upon our volume projections, our break-even analysis and such, this project is financially feasible. We can build it, we can run it, and you know, one of the benefits of being a national provider is that you've got the backing of a company that can help subsidize projects of this magnitude. So in my mind, you know, the question before OHS is a simple one, and Ms. Chafin teed it up before, which, like, is the status quo acceptable? Like, should we allow patients who we know need IRF services and that we know aren't always getting those services to continue to receive them in suboptimal care settings? Or should OHS consider this gap in care that Encompass has identified and approve a hospital that'll fill the unmet need? Danbury Hospital suggested in the letter that they wrote to OHS back last November that Encompass Danbury doesn't understand the realities of the market. And I would tell you that they absolutely understand the realities of the market. They just believe that those realities don't need to remain the realities, right? You know, they're here to, and it's a phrase people use a lot, like, it's time to disrupt the status quo. You know, they're asking OHS to look at this and say, it's not okay to just go along business as usual, knowing that there are patients who aren't getting this level of care and, you know, or that are getting it in a suboptimal setting, that it's time for OHS to look at the data and to provide residents with sufficient access to the rehabilitative care that they need. I think we've talked at length, and I thank Dr. Charbonneau about sort of enhancements to the quality of care that the Encompass Hospital would bring. I mean, it starts first and foremost with getting patients into the right level of rehabilitative care, getting them into an optimal care setting for the illnesses and injuries that they're recovering from. She told you these patients are going to see a medical doctor who specializes in rehab on a regular basis and get hours of focused therapy every single day, which they're not going to get in a non-IRF care setting. And this is going to give these patients the best possible chance of sort of meeting their rehab goals and objectives and returning to their communities and to live functional lives. Dr. Charbonneau also walked you through sort of all the programmatic staffing, technology, equipment, facility design features, the things that that Encompass can offer in an inpatient rehab facility that will improve the quality of care in the area. And, you know, it's everything from the open staffing model to the specialized therapeutic space. You got to see the tour today, which I thought was very impressive. The specially trained clinical staff and also just being a facility that's being part of a national network where mostly what you do is inpatient rehab, right? This is their core business. They know what they're doing. They do it all across the country every day with outstanding results. We also talked, just moving on, about the cost effectiveness of the proposal. You know, the freestanding IRFs like the hospital proposed by Encompass cost less in many instances than their hospital-based IRF units. We've put some evidence in our rebuttal to show that. And we've talked kind of at length about the fact that although SNF services on a daily basis may be different, you've got to consider one, that's just a totally different level of care. You've got to consider the length of care, and then you've got to look at like sort of the total episodic cost of care and the fact that patients going to SNFs often end up getting readmitted, and it ends up costing a lot more. So, you know, cost effectiveness is not as simple as just looking at who charges what and saying which one's more. There's a bigger picture there. The applicant does want to ensure OHS that although we are a for-profit provider, and that's been brought up many times, that we are committed to being accessible to all patients, including Medicare, Medicaid, uninsured. Like Dr. Charbonneau said, they are payer agnostic. They don't even inquire about insurance when these physicians are certifying referrals. So no patients are going to be denied care. No patients are going to be, you know, turned away during care as a result of insurance coverage or payment issues. And that's, you know, that's a policy that's in effect at their hospitals across the country. Also, and I think really importantly, the proposal does promote patient choice and diversity of providers. I mean, I heard a lot of the Danbury witnesses talking about patient choice and how important it is, and we agree, right? Patients should be able to be treated in an IRF if that's what a doctor says they need, and if there aren't beds, they sometimes don't have that choice. And Encompass will also be a freestanding facility that's not affiliated with a system, that's going to accept all patients from all sources rather than, you know, focusing on referrals from a particular hospital or system. And I know that, you know, Danbury isn't a closed IRF per se, but a vast majority of their referrals come internally. And I think that's true of most of the hospital-based IRFs. It's just logically what they do. But, you know, Danbury will be there to take from all comers. And then last, I just want to, and I know this has been a huge focus of the hearing, talk about the fact that, you know, this is intended to complement and not compete with Danbury Hospital. We're going to have to agree to disagree on this. I mean, all of our witnesses testified that, you know, we've assessed the need and we can meet that need without impacting their service. I mean, the need methodology that Ms. Chapin did subtracted out their beds. We believe that there is, you know, sufficient volume in the area for us to fill our beds without impacting their IRF. And I mean, you just heard Dr. Aronson testify a few minutes ago that once every couple months they hit capacity and can't take a patient. So, you know, there is a need there, and Encompass Danbury is here now, ready, willing, and able to move forward with this project to meet that need. It's not, you know, it's not a theoretical expansion. So, and we're also committed, I mean, we're committed to working with Danbury Hospital and other providers to educate them on the services, how to refer patients, what we can do for them. And I think it's just going to benefit everyone. And we're certain that if this CON is approved, and if the physicians at Danbury have rehab appropriate patients that they can't care for themselves in their facility, that they will refer to us, because they are good physicians who put the interests of their patients first. And if a patient's in need of these services and those services are available in an Encompass hospital, that's where they'll send them. So that is all I have. And I, again, very much appreciate your time, the time of Attorney Tucci, all of the Danbury witnesses, the OHS staff. Thanks again.
Thank you. Attorney Tucci.
Thank you, Hearing Officer Yondo, and also thank you to OHS staff for all of your hard work on this application. Appreciate the opportunity to make some closing remarks on behalf of Danbury Hospital. In particular, I was struck by the information that we learned during questioning by OHS staff, and I thought it was really instructive in terms of shedding additional light on, really from a general perspective, what this application is all about and how you should be thinking about it. One of the applicant's witnesses commented on how each market is a little bit different. Danbury Hospital agrees with that 100%. Each market is a little bit different. This CON application has nothing whatever to do with the market in Western Connecticut. Instead, the applicant wants you to look at experience around the country and data around the country, and don't look at the actual utilization in Connecticut. Let's talk about averages around the country, and that's how we can justify building a new $40 million hospital with 40 beds. How are they going to do this? This is truly an if we build it, they will come proposal that's before you. You heard what their plan is. They're going to market, they're going to leverage, they're going to target, and that's how we're going to fill up this hospital. OHS staff asked about healthcare equity. Let's talk about healthcare equity. Danbury Hospital is a not-for-profit institution that's been in this state for more than 100 years. They serve all patients, regardless of the ability to pay. Look at, this is an applicant that's in the business of making a profit. There's nothing wrong with that. Absolutely. God bless them if they can make a profit. They figured out what their payer mix is for them to make a profit, and their payer mix for them to make a profit is to have 3% Medicare. You know how many, you know what the Medicaid census, 3% Medicaid. Do you know what the Medicaid census is in Danbury Hospital? We treat 10% of our total patient census, our Medicaid patients, 3 times what they propose to treat. Why? Because they need to focus on the higher level reimbursement patients that come from Medicare fee-for-service in order to make their facility profitable. We've heard over and over and over again, there's a gap in care in Western Connecticut. Respectfully, I would suggest to you that the gap in care in Western Connecticut is the figment of a consultant's imagination. If you look at the logic of what has been presented to you today, this applicant is telling you not that there's a gap in care in Western Connecticut, but that statewide, on average, Connecticut discharges 5 patients per 1,000 Medicaid fee-for-service residents across the state. Not in Western Connecticut, but everywhere in the state. So one wonders why Encompass shouldn't put this facility maybe in a town like New Britain or New London or some other poor community. Perhaps OHS might inquire about why it doesn't make sense to locate this facility in the center of the state, so more of these patients who supposedly can't get access to IRF beds can go there and get that access. One wonders why they chose the counties of Fairfield and Litchfield, which have perhaps the highest per capita income in the state, for their proposal. Let's talk about level setting here, because we want to talk about this market and what Connecticut requires and what the Connecticut approach to determining responsible need is. The first thing that you look at, as I understand it, from the way OHS examines these applications, is what is the existing capacity in the marketplace? Well, we know what the existing capacity in the Danbury service area is. There's an existing provider at Danbury Hospital that operates an inpatient rehabilitation unit that is the same thing as what's being proposed by the applicant, except that it happens to be within the 4 walls of an acute care general hospital. It has 14 beds. It operates, last count, at about 74% occupancy. Once in a while, it gets up to full occupancy. So the first thing you look at is there any data that you've been presented with that shows that there are hundreds and hundreds and hundreds of patients who live in Western Connecticut whose doctors have said, I need to get this patient into an IRF bed, and Danbury said, sorry, we can't take them, got to refer them somewhere else. There's no data that shows that. The next thing you look at is, okay, people are getting older. The community's going to age. There might be more need for these services 5 years down the road. Seems to me, from a public policy standpoint, from an economic standpoint, from an OHS standpoint, you would then say, let's look at the people in the market who currently provide the service. Do they have the capacity to expand when and if there is a need? The answer you've heard today is yes. Danbury Hospital has the capacity to expand. It has the financial resources to expand. The way this works in a responsible way is Danbury can commit $2 to $3 million to renovating rooms that it already has licensed. It can use those as acute care rooms until they're needed to be IRF rooms. It seems to me that's the responsible way for the state of Connecticut to meet the needs of its citizens for IR care going forward. And it can do it a heck of a lot cheaper than $1 million a bed. Let's talk about the math we've heard. My goodness, we've heard a lot of mathematical calculations today. Really what we're talking about here is a mathematical exercise that's based on how, and the answer to that math problem comes out depending on what variables you include in the equation. in the table that you've been presented. So the applicant has done this bed need analysis that Connecticut doesn't recognize, but it says that it should. And it says, let's put in the variable that's really going to make the number come out the way we want it to. Let's put in 13 per 1,000 Medicaid fee-for-service discharges, even though Connecticut has an average rate of 5. And even though the national average is 11, let's put in 13 because that'll get us to the number we need to get to justify building a 40-bed hospital. That has nothing whatever to do with any of the actual utilization of these services in Connecticut. It's a national average that they plugged into a math formula in order to come out with the number that they needed in order to attempt to justify this application. There's nothing wrong with looking at national experience and relying on general data, but you ought to test that against what the real world experience is in this market. The theory that you've been presented with here is because IRF beds get used more in other parts of the country, that must mean that there is a need here in Connecticut. Well, respectfully, I would ask you, why is that so? Since when, under the CON standards, is the standard, if it gets used a lot, there must be need? Utilization does not equal need. Need is supposed to be demonstrated based on history and statistics and data and utilization that is reasonably projected forward. That's the OHS formula. That's the formula that they're asking you to reject. The one that has been tried and true and used in this state for years. I want to talk about two of the other sort of fundamental pillars or assumptions that underlie this application. And we talked about it at some length with the consultant that the applicant has retained. The first pillar is, let's look at, in figuring out how to get to the number we need to get to, let's look at, in order to help us get there, the number of what we call Medicaid eligible rehab discharges. What is that? You know what that means as far as I can understand it? They basically look at some diagnosis codes and they say, Danbury Hospital discharged 3,000 patients who maybe were 65 and had a certain diagnosis or condition in the bill that was sent. And we're going to say that those 3,000 patients, all of them potentially need IRF care. But there's no data to back up in any way how you can arrive at a reliable projection or percentage of that 3,000 patients who just happen to be supposedly rehab eligible as to whether they're really going to even need the service. And the applicant has admitted they have no way to tell you that in any data reliable way. The other thing that is an enormous guess here, at least as I understand it, from what the applicant has presented to you, is we spent a lot of time, I think it's table 10. They identified 10 hospitals all across the state of Connecticut. They've already told you that 90% of their census is going to come from acute care general hospitals, discharges of patients from those hospitals. The 10 of them that they put on that list, OHS asked specifically, give us some mathematical formula, give us some way that we can rationally conclude that you're going to be able to generate hundreds and hundreds of actual patients who are discharged with a recommendation or a diagnosis that they need to go to IRF care. And they told you we can't do it. All we can do is guess. They said it in their own CON. So all I'm asking you to do is apply the standards that you always apply. Think about what makes sense rationally for the citizens of the state of Connecticut. Think about if in fact expansion is needed, how do we best do that in the most cost-effective way for the people of Connecticut? And I would respectfully submit to you, the way to do that is to look at how to expand capacity in the existing service platform that we've built, rather than building a brand new ground up hospital and hoping it gets filled up. Thank you.
Thank you. Attorney Fusco, do you have any last words?
Yeah, just briefly in rebuttal, I mean, I would just ask, and I know you will, but the OHS staff look very carefully at our CON application, at our filings, and Ms. Chafin's reports and our testimony, and all of the testimony here today, because I think many things that Attorney Tucci just said in his closing statements are mischaracterizations of the evidence that's in the record. He's raising questions that have already been answered but haven't been answered, to his satisfaction, and he's speculating about things that he could have asked about today but didn't. So, we rest on our evidence. It's in the record, and we'll be submitting late files, and to the extent that OHS needs any additional information or clarification, we're here to provide that information. Thank you.
Thanks. Arminda, do you have a list ready to read on late files? Oh, you're on mute. And while he is reading this, I'm going to be asking, because I think there were some documents from also the intervener. I'm going to be asking you when he's done reading the list, how long do you think you need to produce these documents? And then I'm going to issue an order on the late files. The record, though, of course, remains open for the late files, remains open for public comment for another week, and is remained open until you get notification from OHS that the record is closed. Okay, Armand, go ahead.
Hearing Officer Yendo is okay. I'm just going to help out if I need to, because most of them were my thoughts. So
okay.
I'll let him go. I'll just chime in. Thank you.
Oh, thanks. Late file number 1 is links to important rates used in your analysis.
So that's like the Medicare fee-for-service beneficiary rate, the national rehab admits rate, everything pretty much used in the methodology that's that we don't have a link for. Some of your reports, if it's an important point, just to give you that more information.
And number 2 is in reference to appropriate occupancy rate at the Danbury Hospital.
No, Ludlow, Mass facility for Encompass.
That's late file 2. Thank you.
Yeah, on question 2.
That's at the occupancy rates at the Ludlow, Mass Encompass Hospital.
Yes, please. Yep.
Oh, and did you want the closest 3 hospitals?
Yeah, closest 3 hospitals would be fine. That'd be good. Yes.
Okay.
And late file 3, assumptions for volumes.
So that's the mathematical calculation for the volume assumptions of 92, 623, 793, and 963 discharges.
4, IRF volumes of 3 closest facilities for the last 3 years.
Hey, sorry, this is Connor Duffy, Robinson Nicole. I believe it's Medicaid beneficiaries crossing state lines to receive IRF care in Massachusetts.
Yeah, I think, thank you, Attorney Duffy. I think this is one I may not have mentioned, Attorney Fusco, but this is definitely something that will be asked of us, and I don't think we have it in the record. So
I'm sorry, is it the volume for the same 3 Massachusetts hospitals?
Yes, because we don't have that, and that will be used and looked at in comparing what your volume estimates for the new facility are as an example of what you've done or what you're doing at other locations. I don't think I mentioned it. I apologize.
That's okay.
Number 5, Medicaid beneficiaries receiving IRF services in Massachusetts.
Yes.
Number 6, quality measures for the last 3 years at the 3 closest hospitals.
So if you, on that one, if you could give it for the facility itself, and then a comparative number for like a benchmark or something. Thank you.
And data to validate 79% discharge to community status. 8, studies confirming reduced mortality, lower readmission occurrence, and ER visits in IRF compared to SNF.
Can you repeat it again? I'm sorry.
Absolutely, absolutely.
Reduced mortality, what was it? What were the other two?
Studies confirming reduced mortality, lower readmission occurrence, and ER visits in
Yeah, that's right.
IRFs compared to SNF.
Thank you.
Number 9, as in relation to Exhibit DD, page 5, utilizing the AHD.com report regarding costs. Number 10, the funding letter.
Yeah.
And that's it from the applicants. And then we have 2 from the interveners that we're requesting.
Inpatient rehab volumes for last 3 historical years for IP patients, and the number of times in the past 3 years that the census was at 14.
Ormond, could you just repeat that second one? I'm sorry, I couldn't hear.
Late file 1, rehab volumes for this is for the intervener.
Yep.
Inpatient rehab volumes for last 3 historical years for inpatient IP patients, and the number of times in the past 3 years that the census was 14. And current daily cost of care for commercially insured and for self-pay. That's all. Thank you.
And how, for both Attorney Fesco and Attorney Tucci, how long do you think you need?
What's today, the 28th? Could we could we take 2 weeks? I know several of us on this call will be having another hearing in just a few days. So
That's fine. That's fine.
Yeah.
What's the date? 2 weeks from today?
Yeah, maybe like the 11th or the 12th maybe of November.
The 12th. Okay. Attorney Tucci, can you get yours by the 12th?
Yes, thank you, hearing officer. That's fine.
Okay, so I'm going to issue an order on the record now that by November 12th, the late files as listed here are due. And perhaps Armand and Brian, maybe since Armand, you have it on your computer, it's out, I think you have it typed up. Maybe we could just issue a letter just as as ordered by hearing officer Yondo, at the at the hearing, the following documents due on November 12th, 2021, and just list them just so there's no confusion. And that could go out next week. It doesn't matter, but I think at least if we have, a nice, neat way to have it, and I know it will be in the transcript, but then at least we could also then put it up on the portal.
Yes.
Does that work?
Yes. Certainly.
Okay, I think that would be great. Okay, well, I want to just, Brian, Orman, is there anything else that you think we need? Okay, well, I do. I appreciate everybody's time. I thought this, everyone was very cooperative. And like I mentioned before, the record will stay open and the hearing for today is adjourned. Have a good evening.
Thanks very much. Good night.
Thank you.
Thank you.
Take care, everybody. Thank you very much.